Now, it's a high index of suspicion. A red hot swollen foot should be considered as Charcot foot until proved otherwise. It could be unilateral, it could be bilateral. Now we are getting a lot of bilateral cases. But earlier, a lot of presentations were unilateral, so all of us have to make it very clear version. You can't miss it clinically. If it is red hot foot, then it is Charcot. Give rest, investigate it, and once you confirm the investigations, then only you plan rest of the management. Now, if you don't do this, this is outcome. If you're not suspecting this, then this is outcome. What you get is, you are seeing different bubbles there, red bubbles, rings. There's a fracture of the calcaneum and the talus. Then it comes to the tarsal bones. Then it comes to the metatarsal. Then you have even at the phalanx. You do get phalanx. I don't know. There is classification-wise forefoot, midfoot, and hindfoot, and ankle. These are the things. How many of you have seen phalanx which starts as a Charcot? Anybody has seen phalanx? It starts Charcot from the phalanx bone. I had some unique patients who are doing yogas, Ungula. They start working on their toes, they start the asana. And he was diabetic. I was shocked. He's presented to me with a huge edema on his foot on the right side. And I just suspected what went wrong with this only at the phalanx. Terminal phalanx, middle phalanx, they are shattered. There is a fracture. My fragmentation is there. Then I took a history. I said, are you doing any kind of yoga where you stand on the floor? He said, yes, I do it regularly. So look at it. A diabetic who have been told to do yoga should do a yoga not putting an entire weight of the toes. That leads to all these kind of fractures. Now, this may end up with ulcer, osteomyelitis, and limb loss. Now, what we understand and practice, radiographic findings or anatomic lesions. Clinical findings, disease progress, as you know, a lot of our research workers have told us, disease distribution-wise, we have classified, joints involvement-wise, we have classified, degree of complication-wise, Roger has classified the same. Now, what is the goal? Goal is not to diagnose Charcot with fracture. Goal is to diagnose Charcot in stage 0. That is what we should pick up in clinical practice. If you are diagnosing and telling patient after bones fracture ho gaya hai, aapko rest lena hai, you have missed it. So our goal is something different. A swollen, red hot, painful foot in which plain X-rays are normal, and that is stage 0. But it is already inflammatory phase where we have to prevent weight bearing there. And that is how we have to practice clinically. Now, Charcot's osteoarthropathy, we need to understand basic classification, simple staging, and stage-based treatment plan in a clinical practice. This is basic classification, acute and chronic. In acute, active, you have active, where I have given you temperature, iron thermometer, where it is very clearly 2-degree difference is there in one of the limb, where you can see on the left side, there is a swollen foot, and then it is hot. On the other side, chronic inactive, both limb temperatures are same, but there is a deformity. Now, what I should do when I see an early acute Charcot foot? High index of clinical suspicion is done. Urgent investigations, what should be done? Dynamic X-ray, weight-bearing X-ray. You should never ask patient to lie on the table. AP lateral has to be on the plate, patient has to keep the foot, and lateral plate has to be kept, and patient is standing, weight-bearing, X-rays have to be taken, then only will pick up all these things. If you are unable to pick up anything in the X-ray as such, weight-bearing initially, stage 0 phase, plan for diphosphonate bone scan, technetium 99, and MRI. These are the 3 urgent investigations if you are unable to pick up anything. So you are clearly seeing all these findings over here. And an X-ray based staging scheme of the Charcot foot must necessarily be incomplete, inaccurate, and impressive. So it's very important that we should step to the next level, where I'll give an example. The patient came to us with a left side foot swell. We took an X-ray, everything was normal, weight bearing. So Charcot foot is in evolution. There, it is in progress. Now the issue is the earliest non-deforming X-ray negative inflammatory stage of the acute Charcot joint of the diabetic foot can be visualized only by use of MRI, because it is in process. And later we came to know that there is a fracture where you can see fragments of bones have come out from the tarsal bones. So we need to work on MRI-based classification. What is MRI-based classification? Grade 0. Absence of cortical fractures, stage, active, presence of skeletal inflammation, inactive, absence of skeletal inflammation. Grade 1, presence of cortical fractures, active, presence of skeletal inflammation, inactive, absence of skeletal inflammation. What is the outcome? If you pick up by MRI in stage 0, there is minimal deformity. But if you pick up in stage 1, there is always discomfort. So this is very, it makes a big difference in management. So you need to pick up everything in stage 0. Then only as a clinical acumen, what we have gathered in the last 3 decades on diabetes, that makes a sense. We are not here to convey a message to the patient that your foot is fractured. No. We are here to prevent that fracture by picking it well in advance. Now, what is the natural history of Charcot? There is acute phase, stage of coalescence, reconstruction, and ends of the chronic. Fine. What is acute? Red hot swollen foot could be unilateral or bilateral. Stage of coalescence, bone fragments are reabsorbed, edema lessens, and foot cools down. A stage of reconstruction, final repair, regenerative, with or without ulcer. The bone may repeatedly hit the floor and create. Like commonly, if it is a midfoot tarsal fracture, the cuboid slips down, and every step the cuboid hits repetitive moderative forces, hit the ground and break the skin. What is chronic Charcot? A deformed foot, ankle, foot or ankle, with or without proper bottom or ulcer. What is my role in OPD? In an affordable group, because I do get rich patients, I do get very poor patients. So I have got very important role to handle those poor patients. I can't keep on asking them get MRI. So I need to address every segment. So the most important here at OPD, after going through these acute and active and MRI workup, we are going to have a differential diagnosis or diagnosis of acute Charcot, how we can confirm it. This is with affordable group straight away. There is a edema, and you have gone for a TCC by confirming MRI and technetium 99, and you have brought back that foot to normal. Absolutely normal after 3 months or 4 months in total contact class. We have got TCC in 2 ways: weight bearing TCC, non-weight bearing TCC. If patient is very compliant, then you should always plan weight bearing where he listens to the number of steps with walking. If patient is non-compliant, always go for non-weight bearing, because he will never listen to any of your commands or any of your advice. What is the differential diagnosis in a day-to-day practice? Cellulitis, it's very clear that total count and CRP is high. Gout, uric acid. DVT, varus gout. Now, plain X-ray, nuclear scan, MRI, history, and inflammatory markers make a big difference. And there is important thing to rule out osteomyelitis and Charcot is, I think we had a very good work by Rastogi, utility of PET-CT with fluorine 18 with WBC labeled CT scan, which made a big difference in detecting whether it is a Charcot or it is osteomyelitis. So a lot of work has been done in PJ Chandigarh by Rastogi, where it is appreciated a lot. Now, staging the patient for success in Charcot, as you clearly see here, that on the right side there is a swollen foot, it is an acute right sharp. We brought it back to normal. How we could get this? In 3 to 4 months. Number one, dynamic X-ray, where it is very clearly seen. You can also appreciate all the tarsal bones are fractured. So immediately we have to put him in TCC. So total contact class, everything non-weight bearing. After we brought it back to normal, we have to put it in long-term offloading. That is a crow shoe. You can ask this patient to go with a normal footwear. He has to be in this Charcot restraint orthotic walker only, which is customized, which we do it regularly by taking all measurements and casting is done, and we prepare this wherein anterior and posterior slab like units are there, which is fixed, and this he has to use it like that. He can't go without this crow shoe. If he goes it, again he is going to break the feet. Now, chronic Charcot with DFT. You can see there amidst. So we just took an X-ray. You can see that the body is hitting the bone down there, and we plan for the surgery. We remove the hitting bone cuboid. We put him in total contact cast, which is just above ankle. See the results in 3 months. 100 days, everything is fine. Patient is back in closure. So this is very clear workup wherein patient has got two thoughts. One is acute offloading, one is long-term offloading. Acute offloading is for 3 months, 100 days. Long-term offloading is lifelong. If you are missing that, patient is going to come back. You have to design an offloading for life. You can't say that I have healed it, now you use any kind of shoes. If he does that, he comes back. Now, chronic Charcot with the deformity, with the DFT. You can see the deformity, entire ankle is tilted. There is totally deformed ankle, wherein the entire body weight is on the lateral aspect of it. So we did the surgery, we took out all the prominent bones in that area, we put them into the system, everything has to be done. And now he is back into process. He is ambulatory. This is what next level, bilateral Charcot, which is going to be a tough job for us to take a decision on these patients and to work on and salvage them and salvage. Thank you.